how do we make the absolute best decisions? Especially when it's about something as critical, as complex as cancer treatment for the people we care about most, as they get older. It's a really profound challenge. Many of us face it, or probably will. So today we're doing a deep dive into medical decision-making specifically for older adults who have cancer. And this isn't just about picking treatments. It's much more about balancing hopes, fears, and all those nuances, the realities of individual lives. To help us navigate this, we're looking at insights from a conceptual review. It was published in the Journal of Clinical Oncology. The article is called Decision-Making in Older Adults with Cancer by Clark Dumontier and colleagues. It synthesizes a lot of evidence and, importantly, proposes a framework to help steer through these tough choices.
Yeah, and the mission, really, for this deep dive is to give you a clearer picture of all the complexities involved. And to introduce this principled framework that's designed to help optimize these really critical decisions, it's all about trying to minimize both undertreatment and overtreatment, making sure care actually aligns with what an individual needs and, crucially, what they value. What's quite fascinating here is how it tries to bridge that gap between, what we know from clinical trials and the real-world situation for older patients who are often, frankly, frailer.
Okay, so let's unpack that central challenge then. The article really highlights a significant gap, doesn't it? Clinical trials, well, they often enroll healthier, maybe younger patients, which leaves oncologists, especially in community practices, with a lot of uncertainty when they're treating older, maybe frailer adults.
Exactly. If you think about the bigger picture, it means the hard evidence we have. Well, it isn't always directly generalizable to the majority of older patients we see in clinics. So that raises a pretty fundamental question. How do we make properly informed decisions when the rule book, so to speak, doesn't quite cover everyone?
Right. And adding another layer here, the article points out the involvement of caregivers, other key people, their influence on how decisions are structured, the actual choice made, that can vary a whole lot. It's rarely just the patient alone.
That whole system.
So navigating this complex landscape, it sounds like you really need a guide. And that's what the authors offer, right? A decision framework.
Precisely. They propose this pretty powerful framework built right on the foundation of evidence-based medicine. And it's not just theory. It's designed as a practical guide.
Okay, so what's at the core of it?
Well, it optimizes decisions based on 3 key principles. First, figuring out the patient's age-related vulnerability. That's done using something called a Geriatric Assessment, or GA.
Okay, GA, got it.
Second, you consider the overall benefits and, importantly, the harms of treatment, specifically in light of that vulnerability score. And third, you absolutely have to incorporate the patient's own values and preferences. That includes understanding the trade-offs they're willing or unwilling to make.
Right. And this is where it gets really interesting. You mentioned the Geriatric Assessment, the GA. That seems central. It's not just about how old someone is in years.
No, not at all.
It's about figuring out who's, resilient enough for maybe more intensive treatments and who's frail and really at high risk for toxicity.
Exactly. It even helps estimate life expectancy, which is crucial for context. And the article notes, efforts are ongoing to build up the evidence base for this. You've got policies now, like the NIH's inclusion across the lifespan. That requires older adults to be included in funded clinical studies. Plus, there's a real push for more rigorous observational studies, especially for those frailer patients often left out of trials.
Okay, so let's dig into the first principle. Understanding the benefits of cancer treatment. The article says the first step is estimating if the cancer is even likely to cause symptoms within the patient's remaining lifespan.
Right. You have to look at the cancer itself. How aggressive is it? And estimate their life expectancy independent of the cancer.
Makes sense.
So, for instance, the article contrasts, say, an indolent, slow-growing, early-stage prostate cancer. In a fit 55-year-old, he's likely to live long enough for it to become a problem. But maybe in a more vulnerable 72-year-old with lots of other health issues, well, their risk of dying from something else in the next 5 or 10 years might be much higher, so the cancer might not actually affect them.
How do clinicians estimate that non-cancer life expectancy?
They can use prognostic calculators. There are tools available, like on the ePrognosis website, things like the Lee-Schonberg Index. And these rely heavily on those geriatric assessment variables, like functional status, comorbidities, cognition.
I see. So, okay, beyond just general life expectancy, how do we look at the evidence for specific treatments? What questions should we ask?
Good question. You need to ask, was this kind of patient actually represented in the study? Their age, their health status, that's generalizability.
Right.
Then does the benefit of the treatment change based on those age-related factors. That's called heterogeneity of treatment effect.
Okay.
And maybe the most crucial one is the outcome measured in the study, like tumor shrinkage or delaying progression. Is that outcome actually important to this particular older patient?
That's a really key point, because most trials focus on survival or maybe tumor response.
Exactly. But how does shrinking a tumor actually translate? Does it improve their function, their quality of life? Does it help them live better, not just longer?
So we need more trials looking at those things.
Absolutely. The article really stresses the need for more patient-centered outcomes in trials: function, quality of life, things that matter day to day. It also suggests that multidisciplinary teams, bringing in geriatricians, palliative care experts, they can really improve those patient-centered outcomes, especially when the evidence from trials is a bit thin.
Okay, so that's benefits. Now let's flip the coin. Principle 2 is considering the harms of cancer treatment. So if a treatment does offer a benefit that matters to the patient, we then have to weigh that against the risks, the toxicities.
Right. And these harms, they're definitely not one size fits all. They vary hugely depending on how intensive the treatment is and, critically, the patient's underlying health status.
The GA vulnerability score again?
Precisely. And what's fascinating, or perhaps concerning, is that even if the chance of controlling the cancer is similar, the harms can differ significantly by age or frailty. The source gives some pretty stark examples.
Yeah.
For frail, older nursing home residents having breast cancer surgery, one study found 30 to 40% one-year mortality.
Wow.
And among the survivors, over half experienced functional decline, lost independence.
That's huge.
Another example, primary CNS lymphoma. In a subgroup of adults, median age 73, receiving treatment, 25% died within 6 months. And largely that was due to complications from their other health issues and treatment toxicity, not necessarily the lymphoma itself.
So the treatment itself caused major problems.
It can, especially in vulnerable patients. One more, acute myeloid leukemia, AML. For patients aged 70 or older getting intensive chemo, one study reported 35% mortality at just 8 weeks. And that's despite reasonable cancer response rates. It really highlights that just because the cancer response or progression-free survival looks okay, it doesn't always mean better overall survival if the treatment toxicity or other health problems are overwhelming.
So this really underscores the need for better ways to predict who's going to run into trouble with toxicity.
Exactly. And that's where the geriatric assessment comes in again. It actually performs better at predicting toxicity than traditional measures like just performance status.
Are there specific tools based on the GA?
Yes. The ASCO guideline, for instance, recommends tools like the Chiargi Score Cancer and Aging Research Group or the ChiarAge score. These use GA components to predict the risk of severe chemotoxicity.
And can using the GA actually help reduce harm?
It seems so. The article mentions recent trials suggesting that GA-guided care, where treatment decisions are adjusted based on the GA results, can actually mitigate toxicity and reduce things like unplanned hospital visits.
Yeah.
And importantly, often without sacrificing the treatment's benefit for the cancer itself.
That's really promising. So it raises the question, doesn't it? How do we make sure these assessments become standard practice to really minimize harms effectively?
That's the implementation challenge, absolutely.
Yeah. Okay, so we've estimated benefits, we've estimated harms in light of vulnerability. Now, the third principle, incorporating values, preferences, and those tricky trade-offs.
This is where it all comes together, balancing the pros and cons within the context of what that specific older adult truly values.
And this is where it gets really interesting, you said earlier, because what's important can shift significantly with age.
Generally speaking, yes. Younger adults might be willing to tolerate more risks, more side effects, for a chance at a longer life expectancy. Older patients often are less willing to trade quality of life for just quantity of life. Maintaining independence, function, staying out of the hospital, those often become paramount.
So how do oncologists actually figure this out? Is it just asking?
It's more than just asking. The article points to validated tools and resources that can help structure these conversations. Websites like Patient Priorities Care or Prepare for Your Care, they offer conversation guides. They help patients actually list specific priorities like, I want to be able to attend my grandchild's wedding, or keep gardening.
Concrete things.
Yes. And fears too, like I'm afraid of not being able to care for myself. And importantly, these tools help gauge whether quality or quantity of life is the main driver for them.
Can you give us an example of how this plays out?
Sure. The article gives a couple. Imagine a vulnerable older man with prostate cancer. Maybe his biggest fear is the cancer spreading, metastasis. So he might prioritize definitive treatment, even if it means accepting immediate risks like incontinence or impotence.
Okay.
Or, flip side, maybe he deeply values maintaining his current function and independence right now. In that case, he might prefer active surveillance, just watching the cancer closely, even if it means accepting a slightly higher risk of metastasis down the road.
So same diagnosis, potentially very different choices based on values.
Exactly. Or think of a fit older woman with stage 3 colon cancer. Maybe she really wants to maximize her chances of living longer without recurrence, so she desires intensive adjuvant therapy. But another woman in the same situation might say, you know what, the side effects of that intensive chemo really scare me. I prioritize my quality of life today. So she might opt for a less intensive option, consciously balancing the potential survival gains against the toxicity risks.
It's about making the trade-offs explicit.
Yes. And there's another tool mentioned, the best case, worst case scenario. It's gaining popularity.
How does that work?
It helps patients visualize potential outcomes more concretely, instead of just talking percentages. For instance, one study used breast cancer trial data to show patients, okay, with this chemo, best case, here's what survival looks like. Worst case, considering side effects and other factors, here's what it might look like. Makes it much more tangible.
That sounds incredibly helpful. But, these decisions, they rarely happen in isolation, just between the doctor and patient. There's often family, caregivers, a whole social context. Let's unpack that later.
Absolutely vital point. Real-life decision-making is embedded in relationships. Family members, caregivers, the whole healthcare team, they all provide input.
And that can get complicated, right? What happens if family members try to maybe shield the older person from bad news?
That definitely happens. Attempting to withhold information, especially about prognosis. The article highlights that family influence tends to be higher among older individuals, and also sometimes in certain racial and ethnic groups.
And the article makes a critical point about the research itself here, doesn't it?
It does. It notes that many studies on shared decision-making have primarily involved non-Hispanic white participants.
Meaning the models might not fit everyone?
Exactly. They might not generalize well. And the article is very clear on this. While culture absolutely can influence preferences, physicians should never stereotype patients based on their background.
So what's the alternative?
Active engagement. Physicians need to actively engage both the patient and their caregivers, work on communication skills, build trust. It's about understanding the individual's perspective, not making assumptions.
The article also introduces this idea of a decision-making unit. What's that about?
Yeah, it's a concept borrowed, I think, initially from policy decisions, but applied here to families or groups making a health decision. It helps categorize how the group works together. Is there one dominant leader calling the shots? Does everyone act together as a single group? Or are there sort of coalitions or alliances within the family?
Ah, okay. Understanding the family dynamic.
Right. Understanding those dynamics and also the prevailing values within that unit. Maybe they really value equality or individual choice, or perhaps there's a sense of fatalism understanding that can really guide the shared decision-making process towards an outcome that feels satisfactory for everyone involved.
Makes sense. Now, shifting slightly, the article also talks about the psychology of decision-making, biases and things like that.
Yes, this is crucial. It turns out both oncologists and patients can be influenced by various cognitive biases during this whole process.
How does that happen?
It often comes down to a failure to properly balance two types of thinking. What psychologists call type 1 thinking. That's the fast, intuitive gut reaction kind.
Okay.
And type 2 thinking, which is slow, deliberate, analytical.
And we need both.
Ideally, yes.
Yeah.
But emotions can sometimes hijack the process. There's something called the affect heuristic.
Affect here.
Yeah, basically strong emotions clouding judgment. A patient's intense anxiety or depression might lead them to push for choices that aren't necessarily evidence-based. Or conversely, an oncologist's own fear of the cancer spreading might unconsciously push them towards more intensive treatment, even if the evidence for benefit in that specific patient is limited. A healthy mix using both intuition and deliberation usually leads to better decisions.
And there's one bias specifically mentioned regarding older adults, ageism.
Yes, a really important one. Negative attitudes, stereotypes about aging. It's insidious.
How does it affect care?
It can lead to clinicians or even patients themselves deciding against beneficial therapies simply because of age. It can lead to poorer access to care, worse communication, maybe a more paternalistic approach where the doctor just decides what's best without real discussion.
And patients can internalize it too.
Absolutely.
Well,
Self-ageism. An older adult might think, oh, I'm too old for this treatment, and not even seek it out. The article is emphatic. Decisions should never be based on chronological age alone. Never.
So, given all these potential pitfalls, biases, communication challenges, how do we ensure true informed consent?
That's the goal. And true informed consent requires promoting understanding. Understanding the disease, the treatment options, the likely outcomes, both good and bad, and the prognosis.
But understanding prognosis can be difficult.
Very difficult.
Well,
Studies show a really high percentage, like 50 to 73% of older adults with advanced cancer, either have a poor understanding of their prognosis or their understanding is very different from their oncologist's view.
and that matters because...
Because poor prognostic understanding is linked to choosing more aggressive, burdensome care towards the end of life. Care that might not align with their overall goals.
Is there anything that helps improve that understanding?
Palliative care involvement has been shown to significantly improve disease understanding and alignment of care with preferences.
Okay. And then there's the fundamental question of capacity, right? Can the patient actually make the decision?
Essential. We need to confirm decision-making capacity. That generally involves 4 things. Can they understand the information? Can they express a choice? Do they appreciate how the information applies to their own situation? And can they reason through the options?
And just having some cognitive impairment doesn't automatically mean they lack capacity.
Correct. That's a crucial distinction. Cognitive impairment alone isn't incapacity. But if a patient does lack capacity, then a designated healthcare proxy or surrogate decision maker needs to be involved.
One last point on this section. How much should the doctor guide the decision?
Ah, yes. The article touches on that debate. How much help should the clinician give with the final choice? Extremes are generally avoided, being totally paternalistic, I know best, or completely hands-off, it's all up to you, I offer nothing.
Somewhere in the middle.
Usually, a patient absolutely has the right to ask for a recommendation, and if they do, the physician should provide one, thoughtfully grounding it in that patient's stated values and preferences. Some argue, actually, that stronger clinician recommendations are often preferred, especially when uncertainty is really high. Patients can't be expected to be experts in navigating all the complex medical evidence themselves.
Okay, so bringing this all together, what's the ultimate goal? What does this mean for the big picture?
Well, the article concludes by really highlighting that biased, uninformed, or poorly communicated decision-making too often leads to those 2 bad outcomes we mentioned at the start, undertreatment or overtreatment.
Denying beneficial care or giving harmful or pointless care.
Exactly. And ASCO, the American Society of Clinical Oncology, their research priorities back in 2021 specifically included investigating personalized care guided by the Geriatric Assessment precisely to minimize these problems.
Their article also points out that the terms themselves, undertreatment, overtreatment, can be tricky.
Yes, they can carry their own biases and lack precision. Sometimes labeling something as potential overtreatment might paradoxically lead to undertreatment if clinicians become overly cautious.
So how do we fix that?
The authors propose shifting the definitions, moving away from purely disease-centric criteria, like just focusing on survival, towards truly patient-centered criteria.
Which means
Including function and quality of life as core outcomes when judging whether care was appropriate. Was it aligned with what mattered to the patient, not just what happened to the tumor?
Makes sense.
So in the end, the source really emphasizes that sound shared decision-making is just essential. It's a principled approach. It actively engages the patient, their caregiver, allows for both that intuitive gut-feeling reasoning and the careful, deliberative thinking. And this process itself, just having that good communication and shared understanding, even regardless of the final impact on survival or function, it significantly improves communication and patient satisfaction with their care. And that's a profoundly important outcome in its own right.
So, as we wrap up this deep dive, it's just so clear, isn't it? Decision-making in older adults with cancer is this incredibly complex tapestry. It's woven with medical evidence, yes, but also deeply personal values, family dynamics, those subtle cognitive biases we discussed.
Absolutely. And the framework we've explored today, the one centered on that geriatric assessment, it really offers a powerful lens, a structured way to approach these choices. It helps ensure that the intensity of treatment aligns with the patient's vulnerability and that the expected outcomes align with what that individual actually prefers. And really highlights that the process of deciding how that conversation happens, that is an outcome of profound importance itself.
Definitely. So here's a final, maybe provocative thought for you to consider. How might actively incorporating something like a geriatric assessment and having these explicit discussions about patient values, how might that transform healthcare beyond just cancer treatment? Could it improve decision-making across all complex medical fields for older adults? Something to think about. What stands out most to you from today's deep dive? We really hope this exploration has given you a valuable shortcut to being well informed on this critical topic and maybe even sparked some new questions for you.